Hello, and welcome to the Osteogenesis Imperfecta Foundation's monthly podcast. My name is Petra Harvey, and I am the Program Director at the Osteogenesis Imperfecta Foundation. On each podcast episode, the OI Foundation brings you information about the diagnosis and treatment of osteogenesis imperfecta, presented by an expert in the field of OI and rare bone disease. The podcasts are a part of an ongoing educational effort of the Brittle Bone Disorders Consortium, part of the National Institutes of Health Rare Disease Clinical Research Network. The professional education activities of the Brittle Bone Disorders Consortium are led by the OIF. Our podcast today will feature Dr. Suken Shah, the Division Chief of the Spine and Scoliosis Center at Nemours Alfred I. DuPont Hospital for Children in Wilmington, Delaware. Dr. Shah participated in the most recent OI Foundation scientific meeting and published an article titled The Spine in Patients with Osteogenesis Imperfecta. Today, Dr. Shah will be discussing Basilar Invagination, whom to screen, how to diagnose, and when to treat. Welcome, and thank you so much for being with us today, Dr. Shah.
Thank you so much, Petra. It's my pleasure to be here.
Awesome. Okay, so we'll get started with the first question. In your experience, what type of spine issues are most common for people with OI? And are the issues usually connected to their scoliosis, or are there other issues as well that you see more often than others?
Well, as your listeners know, osteogenesis imperfecta is characterized by poor bone fragility. And what that means is not only are the long bones affected, as many of our patients know, but the spine can also be affected. The more severe types of OI, the more involved the spine. And the spine is like other bones in that it has a hard outer shell and a spongy center. The spongy center can become extremely soft, and it makes the outer covering of the bone soft as well. So scoliosis happens in OI in two different ways. One is the individual spine bones become fragile, they fracture, and they become misshapen. And the other is that as a small curve develops and a child is growing, the curve can get worse with growth. So we think that the more severe types of OI develop more severe scoliosis. They get small curves at an earlier age, and during the pubertal growth spurt, these curves can get bigger. So the issues connected to scoliosis are everything that the scoliosis can affect. It can cause pain with sitting or other activities. It can cause a problem with breathing or diminished pulmonary function. And as the scoliosis is progressing, or if the child gets small compression fractures, they can get pain just with different movements. So we see some of those other issues as well. But commonly, the curves are noticed either by the primary care practitioner, but most commonly the parents. When the parents are taking care of them, either bathing or dressing them, they'll notice that maybe their shoulders are uneven, or their ribs are sticking out, or their shoulder blade is sticking out, or they're sitting off to the side, or they have a crease in a place on their back where they didn't have before. These are the typical signs, external signs that a child may have scoliosis.
Okay. Thank you. And can you treat scoliosis with surgery, or what are your preferred treatment strategies?
Well, when a curve is small, it's very important to recognize it. So that's where screening comes into play. And even if children with OI are not seeing their doctor on a regular basis or seeing an orthopedic surgeon on a regular basis, when there is a visit, in addition to examining their limbs or if a broken bone is being treated, they should always examine the child's back and screen for scoliosis and screen for some of the other problems that can develop in the spine in children with osteogenesis imperfecta. And generally, scoliosis can be treated non-operatively. You can follow small curves by X-ray, and you can treat some small curves with positioning devices like changing up the wheelchair or using a very soft brace. But the hard braces that we give teenagers with idiopathic scoliosis generally aren't a good idea in children with osteogenesis imperfecta because they can deform the ribs, and you shouldn't really apply that kind of pressure on the rib cage with soft ribs. So we generally don't use those hard braces to manage scoliosis in OI, but from time to time, some providers do use those. One thing we do is getting scoliosis x-rays is an interesting question. Naturally, kids with OI are getting x-rayed a lot. Every time they have a broken bone or being treated with surgery, there are some x-rays involved. What we have to do is be very aware that radiation is cumulative, meaning that the number of x-rays that a child has in his or her lifetime can add up and can cause other problems like bone malignancies or other types of cancers. So we have to limit our use of radiation in these children. At the same time, taking care of them is difficult without x-rays. So the bottom line is not x-ray too frequently. X-ray when there is a treatment decision to be made, but don't blow off getting x-rays when you actually see an external problem like scoliosis. One thing that I should have mentioned from the outset was that you did ask about the other problems that a child with OI can get related to the spine. Now, scoliosis is the most common because of the reasons we spoke about, but kyphosis can also happen. And scoliosis is a sideways curvature of the spine. Kyphosis is a forward to backward curvature of the spine, or where the child can be hunched over because the bones become very fragile. The other thing that we'll speak about a little bit later is craniocervical junction problems, or where the head meets the top of the cervical spine. We can get issues related to basilar invagination, or BI, and we can talk a little bit further about that. But just like you can get problems at the top and the middle, OI kids can get problems at the bottom of the spine, where the lumbar spine meets the tailbone at the lumbosacral junction. They can get stress fractures there called spondylolysis, which can be painful. Or they can get spondylolisthesis, where some of the sacral vertebra or the lower lumbar vertebra are sliding forward. This again is related to bone fragility, and the bones can become stretched out like saltwater taffy. But the main issues that we're dealing with in growing children especially are scoliosis.
Okay. We do get a lot of questions about kyphosis and spondylolisthesis. So that's great that you mentioned that. What age would you recommend screening for the spinal manifestations of OI?
Well, because scoliosis can get worse with growth, we recommend generally that school-age children should be screened for scoliosis. Now, it can be that scoliosis can present even in an infant. We've seen some pretty severe cases of scoliosis even in children as young as 2. And again, it goes back to the type of OI, where the more severe types can get scoliosis a little bit earlier. But generally, school-age children, so first grade or so, should be screened for a curve. And because the kids are typically thin, we can certainly see their spine through their skin, and we can monitor them just like we do teenagers for scoliosis of the idiopathic type. We're looking for those things I mentioned before: asymmetric shoulders sitting off to the side, ribs sticking out or rotated. And then in a subsequent visit in 6 months or 1 year later, we'll try to document whether that curve got worse. And at some point, we should do a baseline x-ray and then see if the curve is getting worse with growth. So because scoliosis can get worse with growth, it's very important to screen children, especially more frequently, when they're going through their adolescent growth spurt. As they go through that very rapid phase of growth, small curves can become bigger very quickly. Now, if their bone is fragile on top of that, they're not being treated with bisphosphonates, and they're getting microfractures on top of growing, then the scoliosis can become very big and very stiff very quickly. So bisphosphonate therapy, or medicines like pamidronate, have really become important in the management of scoliosis, because there have been numerous studies showing that when bisphosphonates are given early to these kids, they they don't get as big of curve progression. Their curves don't progress as rapidly. We may be able to change the natural history of the disease with bisphosphonates. So we're very encouraged by some of this new work in that area.
Okay. Is there an angle of spine curvature that you would recommend surgical intervention?
Well, typically patients will notice some problems related to having the curve at around 40 or 50 degrees. That's when we know also pulmonary function gets affected. And there's nothing magical about 50 degrees, but what we notice about a curve that large is that gravity, they tend to lose the ability to compensate. And then gravity sort of takes over and makes the curve progress much more rapidly. So it's been our practice to suggest that something might need to be done in the future when curves hit 40 degrees. But at 50 or 60, we're really trying to have that conversation with the family that something should be done, and we recommend something should be done. Now, that's just picking a number, but every patient is unique, and the most important thing to take into consideration is the age of the child and the remaining growth of the child. If a 6-year-old had a 50-degree curve, we wouldn't recommend the same type of surgery we would recommend to a 17-year-old. It's because a growing child needs to keep growing that we have strategies in place to either delay surgery or do surgery that will maintain the growth of the spine, the ribs, and the lungs until a later date when a child becomes a young adult and is more eligible for a traditional type of fusion surgery where it essentially does stop the growth in the spine. But if you're already done growing in that area, then it's not a big deal. But if you're only 6 years old and you need to have the lung capacity to live as an adult, we don't recommend a standard fusion for those children. We'll really try to put surgery off as long as possible or use some of the newer technology by way of growing rods or something that can be adjusted as the child grows.
Okay, I see. So switching gears a little bit, we get a lot of questions about basilar invagination here at the OI Foundation. Can you tell us a little bit about BI, what the treatment is, and what someone can expect if they're told their child needs surgery for their BI?
Sure. BI is a really interesting phenomenon. It's not new. People have known about this for at least 30 years. But it seems to be something more recognized in the OI population. So what BI can stand for is basilar impression or basilar invagination. Now, they may seem similar, but they're actually a little bit different. And basilar refers to the skull base. And impression means that one of the top cervical vertebrae is poking into the hole called the foramen magnum at the base of the skull where your brainstem and spinal cord exit. So the brain lives in the skull, and I'll refer our listeners to Figure 4 in the article where we've got a picture showing what the skull looks like, how the bottom of the brain and spinal cord come out of this hole called the foramen magnum. Now, numerous previous investigators have described these lines to try and make sense of some of these measurements. But when the top of the cervical spine or the Dens process goes into the foramen magnum, you can imagine how that can cause some compression of the brainstem. So platybasia means that the base of the skull becomes flat. Normally, that's a pretty round structure in patients without OI, but in patients with OI, it becomes kind of flat. That's the first change we see. Basilar impression is when the top of the cervical spine or the Dens process pokes into that hole and causes it to be a little bit tight, but typically there don't seem to be any symptoms. Basilar invagination, however, can be really dangerous. That's when the base of the skull is extremely flat and the skull has settled on top of the neck, and the neck has not only just poking into the bottom of the skull, but it's actually growing into the skull. And that can really compress some of the very important structures at the bottom of the brain. This can cause symptoms like sleep apnea. It can cause trouble swallowing, severe headaches, visual problems, trouble speaking, and a general loss of neurologic function even to the arms and the legs if it's long-standing and very severe. And it can also cause problems with the fluid around the brain and the spinal cord called the cerebrospinal fluid. If that gets obstructed, sometimes it can result in a cyst formation in the spinal cord, such as seen at the bottom of figure 4C, where that patient has pretty severe basilar invagination and has formed a syrinx in the spinal cord or excess fluid in the middle of it. So she was pretty symptomatic. She had bad sleep apnea. She was dropping things. She was having severe headaches related to the fact that her spinal fluid just wasn't circulating properly. After being treated for her BI, her symptoms improved pretty dramatically. But not everyone with BI needs surgery, and that really needs to be something that your listeners remember. We know that a lot of people with OI can get BI, but not everybody needs surgery. The surgery can be pretty complex. It certainly has its share of complications, but it's been our recommendation that unless a child with OI is symptomatic with some of those or a few of those things that I just mentioned, like the sleep apnea, severe headaches, trouble swallowing, trouble with speech, upper extremity dysfunction, or trouble using their hands, then certainly the risks outweigh the benefits. The benefits rather outweigh the risks of having that surgery done. But if you just have an MRI showing BI and you're examined by a doctor and not found to have any symptoms, then you can be observed.
Okay. Thank you. So what advice could you give parents as they try to decide what type of treatment is best for their child with issues that involve the spine?
Well, if we could talk about BI for a moment, I think I just want to summarize that if they're told that their child needs surgery for BI specifically, I would really recommend that the parents understand why surgery was recommended. Was it just because of an MRI scan, which, by the way, is the best way to diagnose how severe BI is, not just by X-ray, but by MRI? But be very clear about what those symptoms this doctor has found and why that justifies surgical treatment. Now, there are different types of surgical treatment for BI. The most sort of involved and in vogue in the early part of the 70s and 80s was to actually go through the mouth and take off part of the bone that was poking into the brain. We think there are better techniques now. One of them is using traction to actually slowly, gently lift the skull off the spine, indirectly decompressing that area or indirectly removing that bone from poking the brain, and then fusing the skull to the top of the cervical spine. That hopefully will prevent that settling from recurring. Other ways are to use minimally invasive techniques to remove the bone that's poking the bottom of the brain, not by going through the mouth, but underneath the chin or through the nose or some other minimally invasive techniques. And so just as other patients have benefited from technological advances in spine surgery, we've made a lot of advances in the treatment of spine problems with children with OI. Now, regarding best advice for parents when they try and decide what treatment their kids may need for other spine problems, I would say that they have a trusted provider in their area or at home who can really be their go-to person for their everyday OI care. But when it comes to some of the more complicated things that traditionally some people may not have experience with or may be intimidated by, I would really recommend that they go to a center that has a team of experienced providers, not only familiar with OI, not only familiar with the genetics and the medical treatment, but children with OI have multiple issues related to pulmonary problems. They need to have good anesthetic technique to limit complications. They may need other providers like neurology and pain management. And hospitals like Nemours have really strong multidisciplinary teams. That means that each of the players on our team is an expert in their area as well as an expert in OI. There's very good communication. We discuss these cases beforehand and try and anticipate problems before they become problems. I would recommend that parents seek a high-volume pediatric center, which by its nature has a lot of experienced providers in that area, and especially people who have really dedicated their careers to studying OI or other rare bone disorders or skeletal dysplasias. And this way, the high-volume centers really have the best track record for the lowest complications and best outcomes because they've seen these issues before. They may have experienced complications in the past, but they've taken action and used continuous improvement to make care better. I think that OI can be a very intimidating problem for typical orthopedic surgeons. They are very intimidated by the bone, by the deformity, by the lack of experience in some of these techniques. And so I think experience in handling these children is very important.
Okay, great. So it looks like we're just about at the end of this recording. Thank you so much for joining us today, Dr. Shah. And if listeners have any questions, do you have an email address that we can put on the slide that you'd like to share with them?
Oh, yes. Thank you very much. Our email would be my name, Suken, S-U-K-E-N, Shah, S-H-A-H, at Nemours, Nemours.org. And either I or my nurse practitioner, Alicia McCarthy, would be in touch with your listeners if they have directed questions, certainly within a day or two. And I think the article, although written for medical professionals, we know that OI families are very sophisticated and would enjoy reading this article. And I just want to point out a couple of things, and I think you're going to be attaching this. But Table 1 summarizes the Salon's classification of OI. Figure 1 shows how some of the bones can undergo compression and lead to progressive scoliosis. Figure 2 and Figure 7 really shows cases of severe scoliosis that we've treated successfully and have really helped functionally and helped the quality of life of those patients. And then finally, Figure 4, which we alluded to in the past, shows the issues with basilar invagination and some of the complex anatomy involved. And Figure 5 shows someone who was treated successfully for BI with the technique that we described.
Excellent. Thank you so much for that. That article is great, and we did a review on it in the most recent edition of the OI Foundation's Breakthrough newsletter. So thank you again for joining us. We really appreciate you talking on this important subject. So we'll be back for another podcast next month. We hope you tune in. Thanks again. Bye-bye.